Hi. All right, we'll get started out. I see some people are still joining, but we have just a little bit of introductions to go through here. So I want to say welcome to the 2023-2024 kickoff of the Current Cancer Genomics webinar series brought to you by the Clinical Genomics Consortium, Cancer Genomics Consortium Education Committee. I'm Dr. Deb Ritter from the Clinical Genome Resource, ClinGen, and the CGC Education Committee. And with me here today also is Dr. Celestino, the incoming chair for the CGC Education Committee. We're excited to start out our series on a topic that we all struggle with and are challenged by, those variants that are low penetrance or risk alleles, and especially when they're found in the cancer context. How do we handle them? How do we communicate about them clearly? And what guidance is there on evaluating them? So we have invited the ClinGen Low-Penetrance and Risk Allele Working Group chairs, Drs. Matt Lebo and Ryan Schmidt, along with their coordinator, Marcy Steves from Color Genomics, to talk to us about some of the work they're doing in this space. So before we turn it over to them, just a few reminders. We do have an evaluation survey that we will send out towards the end. And we ask everyone to please fill out the survey by Friday, September 8th. We have some exciting webinars coming up, including the recent VIC CGC ClinGen oncogenicity standards. So stay tuned for an announcement on that, and the survey asks for your input on upcoming topics. In addition, the CGC members and members only can get PACE credits from this webinar. So to receive the credit, you must fill out the evaluation survey, and we'll give out the PACE credit code about 5 minutes from the end. So make sure you stick around. Lastly, please remember to put questions into the Q&A and not the chat, as we will have time at the end for questions. And just to note, you won't come off mute, and the moderators are the only ones that will see the questions if they're put into the Q&A. So don't be shy. You can ask anything you've ever wanted to about low penetrance and risk alleles. So all right, with that, Ryan and Matt, please introduce yourselves and take it away.
All right, let me start by sharing the slides. Hope everyone can see my screen now. Does that look good?
Yep.
So I'm Ryan Schmidt. I am from Children's Hospital Los Angeles. As Deb said, Matt and I are co-chairs of the ClinGen Risk Allele Low Penetrance Working Group. And I'll let Matt and Marcy give a quick introduction. Want to go ahead, Marcy?
Sure, thank you. So my name is Marcy, and I help coordinate this group. We are always happy to have new members. So if you are interested in reaching out and joining our group, I would be the person that you would contact. We typically have been meeting about once a month, although lately we've been meeting a little bit more frequently. We have a couple of smaller subgroups for more focused interests, and we're always happy to have people join our group. So as you listen to kind of the work that we've been doing, if you're interested in contributing to some or all of the activities that we do, please reach out to me, and I would be happy to help you get plugged into some of our meetings and tell you a little bit more about kind of when we meet and how to get all that going.
Sure. I'm at Lebo. Sorry, my video is not seeming to work, but I am from Mass General Brigham, and with Ryan co-chair this working group, and really have been trying to, as you'll see, we sort of tackle the risk allele stuff first, and now diving more into the low penetrance side of things, and hopefully have some good discussions about that side of things too as we get to the chat. So
okay, great. So let's get started. I'll start off. Thanks everyone for attending and your interest in this topic. Thank you to Deb and all of the organizers for inviting us. It's really great to share the output of the work coming out of our working group, and also, more importantly, to get your input on some of the more active ongoing topics. So we'll jump right into it. So genetic variants contribute to in different ways to disease. So you can see on this plot that we have penetrance on the y-axis, we have allele frequency on the x-axis. We've seen many versions of this type of plot in the past, but we see up in the upper left that Mendelian disease variants, they tend to be high penetrance and rare, right? Something that's rare and severe that causes a monogenic disorder. In contrast, in the bottom right, you have variants that do have some genetic impact that you can identify through a GWAS study, but that impact might be very, very small. And there also need to be environmental and other genetic contributions to cause disease. Then there exists this space in the middle where you have variants that are lower frequency, and they have kind of intermediate penetrance. And this is the area that's kind of tricky, that we stumble across a lot of times in our day jobs in clinical laboratories, in terms of identifying variants and trying to let people know what they mean clinically. So this is the space right here that our working group is interested in. We're interested in clinically significant variants by themselves, right? Something that you might report out that might be used in some clinical decision making, without taking into account many other variants in the same or other genes. So something that's clinically significant with incomplete penetrance, regardless of variant type. So it doesn't matter if it's an SNV or CNV or structural variant, any genetic variant could be considered. And keep in mind, a lot of the guidelines that we work with in today's world, at least, they pertain to Mendelian disease up here. So why are classifying variants at the low end of the penetrance spectrum? Why is that a challenge? Frequently, they're more common in the population than expected for the disease. And that's something that has traditionally been criteria for something being benign. So then you have a scenario where there's evidence that something might be disease-causing, but there's also evidence from the population frequency data that it would say it's benign in the traditional high penetrance or Mendelian frameworks. Other traditional measures of classification might not be able to be used. So you might not see the variant segregating with disease as reliably in family studies, and functional studies might not necessarily be positive. They might not be calibrated to show a subtle effect. They might show no effect. It's even possible that the variant that you're identifying might be linked to the actual causative variant, which is unknown. So you could have something that's in cis and in linkage disequilibrium, that you're not even looking at the causative variant. Another thing is, it's difficult to define when increased risk is clinically significant. So that obviously differs depending on the disease area, but there's no consensus at this time as to what level of risk is something that's clinically significant and is reportable, and practices vary from laboratory to laboratory. And all of this leads to a large rate of discrepancy in ClinVar, as we all know. So our working group's task is to try to bring people together to harmonize things, and hopefully get a more consistent and reliable terminology and interpretations in this space. But recognizing that at this time, we really have no universally agreed upon terminology. And if you read the Richards et al. SVI guidelines in 2015, at the very end, it's kind of a footnote. They mentioned some possible terminology for this space, but it's been left to us and others to try to map this out further. All right, so in today's presentation, we'll talk a little bit about terminology. We'll talk about risk alleles, and then later we'll talk about low penetrance variants. To give you a preview, we're going to say that those are two distinct entities, and we're going to formally recognize them. We've done more work in the working group for these risk alleles, which have a lower penetrance associated with them than the low penetrance variants. The things that we've done thus far revolve around evidence curation. We've proposed a classification framework and some consensus reporting considerations for laboratories. So this work is currently part of a publication that's currently being reviewed. And then at the end, we'll talk a little bit about low penetrance variants and some ongoing work in the working group. And hopefully you all, if we have time at the end, will be able to inform us a little bit about the things that you think about in this space and your practice. Start with the terminology. So here is a slide. Sorry, I'm trying to move something out of the way here. That represents our conception of this space. So you have a continuum of the risk of disease from 0 to 100%. And we've defined some new terminology that we want people to, if they're willing, adopt and use to make things more consistent. And I'll highlight that here on the slide. So the first one is separating the space across the top into 3 buckets based on penetrance. So we have, what traditionally we work with, which are high penetrance variants or Mendelian variants. We also now have 2 new areas of risk alleles and low penetrance variants. You can see that risk alleles lie at a lower level of penetrance than low penetrance variants. Note that on this slide, we did not put, I don't know why that keeps going back, sorry for that, but we did not put a formal quantitative cutoff between these areas, that we weren't able to reach enough consensus to establish that. But it might vary for different disease areas. But in general, we're thinking about things being low penetrance when the penetrance is less than, let's say, somewhere around 50% perhaps. Again, don't hold us to any specific numbers. And then it becomes a risk allele when you're somewhere below 20 or perhaps 10%. That was what the community felt in terms of the distinction between these groups. But again, there's no quantitative threshold at this time. Note that genetic evidence changes as penetrance decreases. So you tend to rely more on association studies to prove pathogenicity for things with lower penetrance, and things with high penetrance, you rely traditionally upon looking at the segregation of a variant with disease in families, and with more rare alleles and publications with small families, you look potentially at proband counts. So following down this figure, the high penetrance variants, they already have a framework, and they have various classification terms that we all know and love. So it's 5-tier classification from benign to pathogenic. Let's go over to the risk allele framework. This is what we've proposed in our submitted manuscript, and the community decided that there would be 3 classification terms that come out of that parallel the pathogenic, likely pathogenic, and uncertain significance. So they're of equivalent confidence between these classification terms across the top. So that's what these arrows are representing. So established risk allele is essentially something that you can sleep well, that it's 99+% chance that this is disease causing. Likely is kind of equivalent to likely pathogenic. It's 90+% chance approximately, and then uncertain would be below that. Note that we don't have anything that exactly is saying that something's likely benign or benign, other than a refuted association, and we'll get into that later. So so here are the terms I want you to take away from the talk: risk allele, low penetrance variant, these different classification terms here: established risk allele, likely, uncertain risk allele, and we have equivalent terms for the low penetrance variants over here that you see, although this framework hasn't been built yet, essentially. The last thing I want you to take away is that there's also the concept of a protective allele. So that's the same as a risk allele that operates in the other direction, essentially, that having that allele is protective of disease. So it's decreasing your risk of disease. So this terminology, a lot of it's currently available in ClinVar now, and we have an up-to-date count of the number of variants that have been classified using these terms, which you see highlighted here on the right. So hopefully this will become more widely adopted, and please consider using these terms if it's appropriate for a variant you encounter where it essentially is having lower penetrance. A lot of people with those variants, they might call it likely benign, they might call it uncertain significance, they might call it pathogenic. Perhaps it's more appropriate now to use some of these terms. All right, let's get into the risk allele. So again, those are the things on the far left with the lowest penetrance associated with them. We'll start with evidence curation recommendations. And the reason we did this is because risk alleles, as I showed in that earlier slide, primarily rely on association studies for their genetic evidence. So we wanted to make sure everyone was on the same page in their evaluation of association studies in the literature so we could try to get consistent results. So before we get into the specific evidence curation recommendations, let's talk about a couple example risk alleles just as kind of a mental warm-up. Many of you have probably seen a lot of these risk alleles in your practice. So here's a allele, the I1307K variant in the APC gene. So it's associated with colon cancer, just like the high penetrance variants in the gene, but the risk associated with this particular variant is quite low. So in association studies, you see it associated with disease with an odds ratio of around 2 approximately. Another variant to consider would be the MIT-F GLU 318 lysine variant. So this variant you oftentimes see tested for hearing loss on panels, but it is associated with a risk for developing melanoma with an odds ratio of between 2 to 5. And then the last one is a thrombophilia variant in factor 2, also known as prothrombin. This variant is in the 3' UTR and has been traditionally called the G20210A variant. And it's associated with an odds ratio of approximately 4 for developing thrombophilia. All right, so thinking about evaluating association studies that you encounter in the literature. So the first thing to think about, and it really is critical, is what is their definition of the disease phenotype? And for CGC, we're thinking about cancer. Perhaps, you have to define, is it a certain type of cancer? Is it a certain group of cancers? In other areas, there are phenotypes that are more nebulous, like neurodevelopmental phenotypes, for example. And it's really critical that the patients are bucketed appropriately, that the people in the disease group have the disease and they have the same disease, and that the people in the control group are not contaminated with people that have the disease or some type of subclinical manifestation of the disease. So for the purpose of this talk, we can't get into all the details of these recommendations, but just to hit on the big picture takeaways, it's really critical when evaluating these that the phenotypes are consistent across studies and that they're well defined and that they're evaluated in a rigorous way, right? We would want them to be evaluated, for example, by physicians in the appropriate area to say someone has the disease phenotype. The next is matching cases and controls. And here's an area where a lot of confounding can happen in these types of studies. So one critical element of this is to match based on ancestry. So there's different levels of matching by ancestry. There's ancestry determined genetically. There's self-reported ancestry. There's individuals that just happen to live in the same country and perhaps are not of the same ancestral background. So those factors can confound the results in these studies. And it's really critical to appropriately match the case and controls. The next thing is the identification of the variants themselves. So it's important that your technology platforms in these studies that are used to identify the variants are the same. So there's no bias introduced by methodological or technical variation. The next thing to bear in mind is the genetic model. So a lot of association studies, they might evaluate the risk of disease from a so-called allelic model. They might assume that the variant's acting in a dominant manner, and they might bucket the homozygotes and the heterozygotes that have the variant and compare that against the homozygotes that don't have the variant. In contrast, they might choose a recessive genetic model where it's taking the only the folks that are homozygous for the variant and comparing those to all other genotypes in a case control analysis. So that should be clear. Additionally, statistical significance is critical. For clinical use, we don't want to take into account anything that doesn't demonstrate statistical significance, but we have to be careful in misinterpreting cases where you think something's significant, but it's not because it wasn't appropriately corrected for multiple hypothesis testing. So that should be part of the approach done in the study. And then strength of effect, which could be measured by the odds ratio, for example. Again, we should only take that forward into clinical use if the result is obtained with statistical significance. Another concept is replication. So many association studies, especially in the early days, they had poor replication. So another person did a separate study in a separate group of individuals, and it did not replicate. So it's really critical for it to be a clinically valid association that an independent population of cases and controls is used to reproduce the result. And you can also generalize the result by showing the result in a group of a different genetic ancestry. All right, so that was a lot. Sorry for all the text. Here's an example of a curation form that you might consider using when you're evaluating an association study. These are the type of things that you want to measure and record and compare across studies. All right, so let's get into the classification framework. So this is in some ways the meat of this recent publication that we submitted. And we hope that this will be adopted and used in parallel to the high penetrance or Mendelian classification framework. So here's the overall set of criteria that the variant might meet. And then those criteria are going to be used to classify the variant in different classifications on the subsequent slide. So we'll walk through these one by one to try to make it digestible. But as noted at the bottom, these criteria work for both risk alleles associated with increased risk of disease, as well as protective alleles, which are associated with decreased risk of disease. As I mentioned earlier, association studies are really the driver of the evidence of pathogenicity. And there are three different strengths of evidence for association studies. So there's very strong, there's strong, and then there's limited or conflicting. And then each of those has to meet three different metrics in different areas. So the first one is the number of individuals studied. We don't want to consider something very strong if it hasn't been looked at in a sufficient number of individuals. We want to see that the result has replicated. And in this case, there's extensive replication with little between study inconsistency to make it very strong. And the third thing is the risk of potential bias. So for very strong, we should be highly confident that this is real, that bias could not reasonably affect the presence of the association. So that was what I was saying earlier. You should be able to sleep at night. It's 99% chance that this is a established risk allele. And it's essentially pathogenic, but for a risk allele. So let's contrast that to limited at the bottom. What would make something limited? If you have a limited number of individuals studied, if there's lack of replication, between large studies that have, approximately equivalent evidence, or there's significant potential for bias in the methodology. One thing to keep in mind with association studies and risk alleles, it's not required that every association study show a significant result. It's possible that you could have 5 studies and 4 of them show a significant result and 1 doesn't for whatever reason. And that could be normal. That does not make the presence of the association just go away. You have to kind of take the totality of the evidence. But if it's 2 large studies and they are conflicting, then that would automatically make it a scenario where it goes into this limited or conflicting bucket. And then in between that would be what we call strong evidence. So there's between 100 and 1,000 individuals studied. You have shown replication. There might be moderate inconsistency, but essentially the result is replicated, and there's no clear sources of bias, although the studies might not be methodologically perfect. So functional studies, they tend to play a stronger role for high penetrance variants, but here they're playing a supporting role. And essentially, they can play that role if there's a well-established functional study that suggests that the risk allele or protective allele alters gene function through a biologically plausible mechanism. And one thing to note is that the effects might be more subtle for these variants with lower penetrance. So it's critical that the functional studies being used are appropriately calibrated with benign variants to show what is the normal fluctuation essentially that you might see in the functional study assay, and what level does it become an effect that might be associated with the risk allele. The last criteria to discuss is a refuting evidence criteria. So before we talked about conflicting, we talked about scenarios where if you're looking at a scale, you kind of have equal evidence on both sides. That'd be conflicting. But refuting is a scenario where an assertion has been made, maybe in a smaller study, and then a very large, well-designed study that is designed in a similar manner, looking at the same population, comes along and does not show an effect. So that would refute the effect of the association with disease. And for that type of variant, we want to ultimately classify as a refuted association. This is the only thing in this framework that is somewhat consistent with the benign or likely benign classifications at the higher penetrance. Okay, so those were the different criteria. With those criteria here on the right, you take them to get you to these different classification terms that we talked about earlier. And it's really a simple process because the association study evidence is really driving everything at the end of the day. A lot of those factors that we consider for high penetrance variants, they just kind of went away. The association study is driving everything. And you may or may not have a functional study as supporting evidence, but that functional study alone, it does not increase the classification level. And last thing to note is that variants without genetic evidence, where there's no association study making an assertion that it's associated with disease, they would remain unclassified. So we don't want people, to take every variant possible in the genome and start to put a classification on it, right? It's only once an assertion is made, then we would put it into one of these different classification categories. Okay, so that was a lot. I hope that wasn't too dense, but we can talk more about it later. Now we're going to get into reporting considerations for risk alleles, and I will turn it over to Matt. And Matt, tell me when you want me to advance the slides.
All right, awesome. Sure. Go ahead to the next slide. So we wanted to, within our working group, we didn't feel like we could dictate reporting strategies for risk alleles, but we also wanted to be able to provide a little bit more guidance to individuals to labs that are tackling these on sort of what general strategies might be in terms of reporting. And so as opposed to sort of creating a framework or things like that, we decided to approach it from a consensus recommendations from our working group. And you can actually see, we'll get to it later on, there's actually oftentimes we couldn't come to a consensus, and we'll sort of detail that a little bit, but there are some sort of general recommendations that we were able to get to. So the first one's pretty clear. Just if you can put information regarding disease risk on the report, it's the best to be able to do that. So that's sort of a straightforward thing. We also wanted to give some, I guess, guidance on when something should be considered a risk allele. And we really felt that, again, as a consensus, that is this 2 to 3-fold increased risk where it becomes to be important clinically. And that's sort of a lower bound threshold of when to even consider something as a risk allele. In a diagnostic setting, if someone does identify a risk allele, we also felt that it should not be considered positive if that's the only variant or variants that are identified, just because that is not the only thing potentially leading to disease in that individual, but it is obviously important to put on the report. We want to definitely report variants. So any variant that is identified in a specific genetic ancestry group, we still felt it's important information to give back more broadly, even if there are some limitations about how that risk is performing in a different ancestry group, just because from a lab standpoint, we never know sort of what someone's true genetic ancestry is. If we're not sort of evaluating it, we might have admixed individuals. There's a whole host of different reasons. So we felt that it was important to still include it, even if you're include on anyone, I guess, for where this variant was identified. We also felt like, similarly, it's not useful to report carrier status for risk alleles. So some of these ones that are only relevant in the recessive model, if you identify just the single variant, it's not useful to actually report it. And then finally, if there is a true causative variant that has actually now been identified, and this does happen where initially the risk variant was seen, but sort of when there was more deeper sequencing, either in the intronic region or wherever it might be, there's now the true functional variant that's on that haplotype is identified. That's the one that should obviously be preferentially analyzed and reported. It still may not be discovered by everyone, and the risk association is still true for the other variant, but clearly the more functional variant is the one that should be really analyzed if possible. We also want to go through different scenarios of when you might encounter risk alleles and sort of what you may sort of do with it. We already talked a little bit about this first one for the diagnostic assay. When you identify a risk allele on a report, you should include it, but not necessarily make their overall report positive. However, in other situations, we weren't actually able to come to a consensus, and it sort of depends on the reporting strategy of the laboratory. So for instance, if you're doing a diagnostic testing, but the indication doesn't match, Ryan already mentioned this mid-F variant, where you would be testing for hearing loss and you identify a risk for melanoma. It really comes down to sort of what the laboratory is deciding to do based upon their consents and so forth. In prenatal diagnostics, it's a little more challenging. There's a lot of variants that are sort of in this borderline neurodevelopmental. Some have some sort of decreased neurodevelopmental effect. And these ones are a little bit more challenging. Again, there was no sort of consensus on how to approach these quite yet, although it's actually a good opportunity to point out that this framework really should apply to CNVs as well, and not just to sort of small variants. Similarly, in secondary findings, I think typically people are not reporting these sort of more risk alleles for secondary findings, unless they're named, maybe like HFE. In TTR, there's another one that's sort of relevant. However, it still has not yet been established whether or not for things like this APC variant, whether or not they should be reported, and there is no consensus sort of within the group. In genomic screening, this actually was consensus to report this, and partly because in a screening assay like this, what you're really trying to do is identify people who are at risk of disease in sort of any form, and this is sort of one of the clearest places where risk alleles are important, is identifying people before they have disease that maybe should be treated or screened differently. And then preconception carrier screening, this was a scenario where the risk is associated with a different disease that's not part of the carrier screen, sort of similar to the diagnostic assay where the indication doesn't match. And we did feel, though, it's a little bit different than a diagnostic assay where you would report the pathogenic association, but not necessarily the risk association. Although, again, this can come down to sort of specific consent and reporting guidelines from an individual laboratory. All right, so that is the risk alleles. Are going to dive a little bit into the low penetrant variants. And so the low penetrant variants are proving to be, as you might expect, challenging. I think we're all struggling with this. And about a year ago, we reached out to the community and sort of said, we'd like to talk to different people that are struggling, come to our working group, show us some of the variants that you're challenged with, that you really have issues with. And so we've really been able to bucket down to similar types of common variants that people are struggling with. And they're all a little different, but overlapping and related. And we want to sort of just put this out there for everyone to see. We don't yet have formal terminology here. We are trying to figure out ways to develop a little bit more formal terminology for these. But we wanted to sort of just put them out here so you guys understand sort of where we're coming from for what we're going to talk about next. And so low penetrant variants, we talked about this. Ryan did a great job earlier. So really variants with just lower penetrance for disease and other variants within the same gene. There's also low penetrance genes. I think from this community, CHEK2 is probably a really well-known one here, where really all the variants have a lower penetrance disease than is typical for Mendelian conditions for other genes with that condition. So that is something that is very related to low penetrance variants, but has some different subtleties. There's hypomorphs, and this is a term that is actually used broadly and in very different forms and doesn't have sort of an established thing. Really just means a variant with reduced function. I think where we tend to see it in recessive disorders, you might have a variant where you can actually have homozygotes in that variant and they do not lead to disease, and you only get disease when that sort of reduced function variant is in pairing with a more severe variant. So there's a common variant in biotinidase deficiency, which is part of the secondary findings list now, where homozygotes aren't expected to have disease, but in combination with more severe variant, you do have sort of more mild or symptoms of biotinidase deficiency. Pseudodeficiency alleles are much more common in the newborn screening landscape, but are sort of relevant as well, where the functional assays may look like a variance causative, but those functional assays may be wrong, or the variant may actually truly be a hypomorph. There's sort of some overlap there as well. And then finally, there is just variants that are more mild in their presentation or that have sort of variable expressivity. And so these variants are more common just because so the fact that someone has eczema isn't really as interesting as the fact they may have more severe skin condition, right? And so these phenotypes may not be captured. They may not be sort of clearly defined. And so there's different ones here that it creates much more of a spectrum. And so these are sort of like the landscape for where people are struggling and having problems. We are going to focus primarily, at least first, on the low penetrant variants, and we would like to sort of dive down into more of these ones. There is a new ClinGen group focused on pseudodeficiency alleles. And like I said, there is a lot of overlap in other things. We're going to start with the low penetrant variants just to try to get some consensus there and then move on to some of the other ones as well. So for low penetrant variants, clearly, as Ryan mentioned, they sit between risk alleles and high penetrant variants. But we still wanted to use the Mendelian framework as a starting point as opposed to the risk allele framework. So just a reminder of what the Mendelian framework is, at least currently. You have different things like population data, computational data, functional data, segregation data, and other things. And so these are sort of things that we wanted to focus on. You can go to the next slide, Ryan. But we also want to be aware that there is new guidelines that are coming out. And so we wanted to be able to sort of tackle those. Oh, sorry, I jumped ahead. We also know that these current guidelines actually don't work quite as well. And there's different reasons for that. So clearly population frequency is higher oftentimes than expected for the disease. And that's sort of like a red flag always starting with these variants. Segregation patterns are confusing. There's many non-segregations, kind of confusing how to deal with them. For some variants where there's functional data, they may actually be borderline in their function. We have no idea how to actually deal with computational predictions yet, or if they're useful. And so this one thing we're actually trying to figure out and tackle. Are there sort of thresholds you can apply? And then things like de novo variants generally are not relevant for low penetrant variants. Maybe for low penetrant genes, but not necessarily for low penetrant variants. So as I mentioned before, there is new guidelines that are coming out where they are sort of utilizing, and we want to be able to utilize those concepts in what we're developing for ourselves. These new guidelines are going to be a point-based system and really based upon evidence. We want to be able to now think about what's coming and apply sort of our framework for low penetrant variants on top of that, as opposed to sort of what's already been developed and sort of won't be relevant anymore. So they are dividing their evidence into 3 general categories: population evidence, clinical evidence, and molecular impact. And we really want to then tackle this from the same sort of standpoint. We actually end up developing 2 subgroups. The first one is that we're working on, we've been sort of very busily working on these over the summer so far, is focused on molecular impact. If we go to think of the things where molecular impact is important, really for low penetrant variants, where it's a little bit more unique, is the functional assessment and the computational prediction, 2 of the things that I mentioned earlier. As opposed to the second working group that we're developing, which is this genetic evidence population frequency working group. We're really trying to dive down to when you should be even considering looking at a low penetrant variant. So right now we're just looking at one of the drafts from the new guidelines about population frequency, and really they give it quite a negative score if it's common. But a lot of our variants that we're focusing in this area are actually more common, would get pretty highly negative scores, and we don't want to do that because then they would never reach the classification status that we need. And so we're really trying to figure out when the genetic evidence can outweigh this high population frequency, and when you would have to ignore sort of this population frequency. And secondarily, I think in sort of a related way, we also need to determine how we can actually generate or utilize case control analyses, especially using sort of general population data like NOMAD or something like that. This is going to be a little bit more challenging and tricky. I think there are some guidelines coming out from other ClinGen groups and potentially approaches here that we're looking into. But really, we're trying to figure out how to apply these methods and these codes specifically for low penetrant variants, and to make sure that we're not overweighting things that we know are not going to be helpful, like lack of segregation or population frequency. So that was pretty quick run through. We are in the process of really diving deep into the low penetrant variants now. As Marcy mentioned, we're always happy to have other people that are interested in working with us in these. We're a pretty open group. And so we're really happy to talk a little bit more at the end of this right now about sort of where you are all struggling and sort of some of the areas that you are looking for guidance into. We would like to acknowledge at least the members for the framework that's under revision. And so I think that is that's the group listed here. We have a lot more active members now as well for the low penetrant stuff. Some different active members as well. And also the ClinGen steering committee and the general ClinGen community that really helped us standardize these guidelines. And actually, as we're presenting the risk guidelines and diving into the low penetrance, the community of people that are interested and really struggling here is grown much greater. And so it's really, even the CGC community and others like that, we're really interested in getting feedback from people about sort of where we can be most helpful, where we should sort of prioritize our efforts. So I think with that, we can probably take some of the Q&A, right, Ryan?
Yeah, thanks everybody for your attention.
Great. Yes, thank you. Thank you so much for presenting. This was really fantastic. So we do have several questions. And again, please remember to put your questions into the Q&A and we can go through them. So one of the first ones here we can start out with, and we'll do questions for about 10 minutes, and then about 5 minutes towards the end, we have an evaluation survey and a code to put up for the PACE credit. So one of the first questions that we have here is about using low penetrance versus incomplete penetrance. So why sometimes you may not know the penetrance exactly. So is there space in the framework there to use incomplete rather than categorize it?
Well, I remember when it was discussed. So the first thing was, I see there is moderate in the Q&A prompt, right? So at first it was discussed whether it would be low, moderate, high, and essentially people felt based on how quantitatively we can define penetrance, it just wasn't realistic. So it was only low. So low doesn't mean ultra low. Essentially, that's where the risk allele is. Low is the term that people preferred through surveying and voting, essentially, to pick for that space in the middle. So that's how we got to low. And then the other part of the question referenced incomplete penetrance. And so that was brought up at the time too, but people didn't prefer that term. They thought that was more ambiguous because it's a relative term rather than absolute term, right? It's incomplete relative to what versus it's just low. So in the end of the day, people for this middle space between the risk alleles and the high penetrance variants opted for the low penetrance. So that's how we got there. But yes, perhaps if something has 30% penetrance, maybe you might feel like it's not low, but anyway, that's the history of.
Great. Okay. Great. All right, so we have another question here from Juan. Most of the risk alleles from GWAS studies are, I'm going to take a stab in linkage disequilibrium to the real culprit ungenotyped variants. So many of the robust associations cannot be reproduced in other genetic ancestry groups of the same variant. Is that?
Yeah, I mean, so we sort of alluded to this in the talk. I think that is a potential challenge and risk, but I think from the standpoint of a laboratorian, we don't oftentimes know the true genetic ancestry of an individual. And so it's much more challenging for us to be able to bucket, and it's probably not truly best practice to try to only give variants back in some individuals and not other individuals. And so we did, even though that is potentially true, I think there's ways to coach that in the evidence summaries that you have that you write up for the variants in terms of where this association has been seen, and that there may be limitations for the association in other genetic ancestries. And so we still felt like from the classification standpoint, the classification is valid. And from the reporting standpoint, it would be challenging for the laboratory to not report it back in everyone. And there's other reasons why you would not want to.
Okay. We have a couple more questions here and a little bit more time. So I think one of these questions here is really aimed about understanding the gene disease relationship. So at a point when you were speaking about, I think this was about the risk allele, it was saying, you wouldn't report this unless you first have an association of the gene and disease. So the question is about, how can you understand the penetrance of each gene in general? And would that be that you're saying you need to have a strong gene disease association in the first place in order to move forward and even have risk allele reporting?
Right. All right. Let's unpack that a little bit because there's a couple of things there. So I think that's building on the concept for the high penetrance variants. You need to say there's a real gene disease association there. There's a process for that people do in ClinGen, for example. And then you're like, okay, I found a variant in that gene, and now we're going to classify it potentially beyond a VUS. For the risk allele, it just keeps it really simple. It's just purely association study based. It's like that's the first and the primary driver. So you don't have to worry about that step with gene disease association for risk allele over here on the low end of things. It's just, is there an association study with a significant result that associates this genetic variant with disease? And that's the starting point. So it's not a two-level process where you do a gene disease association, you go from there. In fact, the risk allele could be out in some non-coding area, it could be intergenic variant. We don't even know how it's working, but if the association study is showing there's an effect with disease and it's something that's potentially clinically significant, then it's a risk allele, could be reported, could be classified.
Okay, and how about then for the low penetrance side, then does the low penetrance or the low penetrance variants, did those then need to have a gene disease? I guess what I'm thinking of is the ClinGen gene curation. Do they need to have a strong gene disease classification in order to then move forward with low penetrance curation?
Yeah, we haven't crossed that bridge. I'm curious. That's important. What do you think there, Matt?
Okay.
Yeah, I think it's probably likely that's going to be true. Because Ryan says
Okay.
we haven't actually had a deep dive into it for yet.
All right, great. All right, let's move on here to, let's see, here's a question about whether it would be useful to have an odds ratio or a population frequency cutoff when using the term risk factor versus or with low penetrance.
So it's really important to note, for back to the risk alleles. The risk allele, calling something a risk allele is independent of population frequency. So you could have a risk allele that is pretty common, you could have a risk allele that's pretty rare, and you might see more of those now that we're sequencing, 100,000 plus genomes, and you can do these association studies. So it's not the population frequency that's making it a risk allele. It's essentially the absolute risk of disease, the penetrance, that it's a very low penetrance. So yeah,
Okay.
so basically risk allele independent of population frequency, and then for the low penetrance variants, which is closer to the high penetrance variants, it's gonna kind of behave like a high penetrance variant, be evaluated and classified like a high penetrance variant, but we have to probably make modifications to allow for a higher population frequency. We don't want to deduct inappropriately to make something that actually is what we would ultimately call pathogenic low penetrance. We don't want to have that be a VUS inappropriately because there's population frequency.
Great. There was another question. I think it got moved to some different section in the Zoom Uverse. But it says, how should later onset of a phenotype, et cetera, how should that affect evaluation of low penetrance variants?
Yeah, I mean, it's probably likely that a lot of these sort of things that are low penetrance, maybe if we all lived 150 years, wouldn't be, right? So
right.
I think we are sort of acknowledging that, I think, with when we're creating these guidelines or working through the guidelines right now for the low penetration variants, we do need to make it clear, especially if we go try to help people figure out these case control analyses, to think through age, individuals' age, both in terms of affected and sort of the general population of how we're doing these, because I think that's where we potentially could get some false signals. And so that really is one that we're very much aware of, and that we're trying to figure out is when you should consider non-segregations as being relevant or not relevant, and that sort of thing. And so I think that is, and likely those ones are also sort of more common than you would expect, right, in the general population, if they're typically a later age of onset than typical for disease. It also sort of overlaps with these like more mild phenotypes, and so there's a bunch of overlapping concepts here that we're trying to tease out and work through, and I think this is one of the ones that we would definitely love to provide guidance for.
Yeah, and then for the risk alleles, ideally you're looking at the kind of the lifetime risk, if possible. But a lot of studies might not have that, so that'd be an important thing to make sure that the cases and controls are matched for age, right? Because you could have something that has a more adult onset that could be a confounding factor.
Yeah. Okay. So I'm going to take moderator privilege here and ask a question that I have, and that's on the uptake of the guidance. So, and then after that, we'll switch over to the evaluation form. But so how are you assessing kind of the uptake of these guidance? And I just say this because, whenever you put out standards amongst the community, you want to know, even though it seems like there's a lot of community support, how are things changing? For instance, many of the platforms right now are not able to curate the risk allele. So we couldn't, assign low penetrance, risk allele, et cetera, in our final curation. So what are some thoughts on kind of the next steps to evaluate uptake?
Yeah. So one area that we definitely want to start doing, and we'd be interested in from this group too, we do want to start working with so one thing you'll notice when you go through our recommendations that we haven't actually really defined and given examples. We've given examples, but in our manuscript we don't say this is an established risk allele, this is a likely risk allele. We want to do that in conjunction with the ClinGen disease expert panels. And so I think that's one area where we can get some quick uptake. We're hoping is that actually using these guidelines and working with some of these disease panels to actually classify variants that they're struggling with that sort of fit this criteria. So that's one area. We showed sort of the uptake in ClinVar, and it's slow, but there is at least some labs and some individuals that are starting to utilize these terms. We're hoping with as the guidelines are released, that more and more individuals will actually classify them and submit the ClinVar and show it in that way. So it's a little, yeah, I mean, you're right. It's we're hoping people will realize the utility of the guidelines and start utilizing them, but it's a little, yeah, we'll see.
All right. Well, wonderful. Well, thank you so much for coming to speak with us today.